University of Hong Kong. I'm Daniel. I'm coming here to visit Southern University. So let me briefly introduce Professor Cowling, and then we'll give the floor to Professor Cowling. So Professor Cowling got his PhD in statistics from University of Warwick at the United Kingdom. And after some time with Imperial College London, he went to University of Hong Kong, and where he is currently the division head and also professor for epidemiology and biostatistics in the School of Public Health. And he is also the co-director of the WHO Collaborating Center for Infectious Disease Epidemiology and Control. And so most recently, he and his team work on recommendations with regard to pandemic preparedness for non-pharmaceutical interventions for the control of influenza. So Professor Cowling is a WHO expert, and we are very honored to have him here to speak to us. So today, his topic is strategies for the use of enhanced influenza vaccines in older adults. Okay, welcome, Professor Cowling.
Thank you very much. I'm quite happy to be here. I'm just passing through on the way to a conference in Charleston, South Carolina. So I'm just here for today. To orient you to my talk, I'm going to talk about why influenza is a problem. I'm going to introduce influenza vaccine and then some new vaccine called enhanced influenza vaccine. And then my question is, what's the best way to use those enhanced vaccine? And it's relatively simple talk, including randomized trial, and then some conclusion at the end. I forgot to put in a slide about Hong Kong. So Hong Kong is a city on the south coast of China, population 7 million. It's a aging population, like many populations in Asia. It's been in the news recently. You can ask me about that after the talk, separate to the topic of my talk. And in Hong Kong, we're also concerned about influenza. So I'll start with myth busting. So there's a common perception, there's a difference between the common cold and the flu. On the left, the common cold, rare to have a headache, no fever, just a little bit of respiratory symptoms. On the right is the flu, prominent headache, sudden fever, severe aches and pains, etc. Much worse. It's actually a myth. It's actually a myth, right? So flu, yes, it can be severe, but I've been doing community studies of flu for 10 years. We find many, many people with laboratory confirmed flu who have the symptom profile on the left. They have no headache, they have normal temperature, some respiratory symptoms, they're sick for a few days, and for whatever reason, they don't get the flu. They have influenza virus infection, but it's not the flu. And it's fascinating. It's one of the big myths about flu, that it's often severe, that it's typically severe. It's not true. Actually, about half the cases in our studies where we pick up cases in the community, about half don't have a fever. So I bust that myth straight away. Flu comes seasonally to the United States, caused by a very small virus, influenza virus, transmitted from one person to another, short incubation period, not that transmissible, which means in theory it should be relatively easy to control. But as I mentioned, most infections are mild, only a small fraction are severe. The group that get infected the most are children. So in a typical epidemic, maybe 10% will be infected, but it's probably 15 or 20% in children. In a typical epidemic, it's more common to be infected for children. For adults, and then particularly for older adults, it's less common to be infected. But if the older adults get infected, if an elderly person gets infected, it can be worse. And on the right-hand side is a figure of mortality, where there are clear spikes in some years, and those are linked with flu seasons. So when there's a big flu season, it has a very noticeable effect on mortality in a population. That's respiratory mortality, but you can also see it in overall mortality. And there are three types and subtypes of influenza virus that circulate from year to year: AH1N1, AH3N2, and then B. And then the strains change from time to time, but our vaccines will contain all three of those. Vaccines have been around for a long time. They're one of the earliest vaccines to be developed. This is from the 1930s. The virus is grown in eggs. So in chicken eggs, put the virus in, it will grow over time, and then the stuff in the egg is tipped out, purified, cleaned up, And so flu vaccines are the most used vaccines in the world now. More than 500 million doses of flu vaccine are given every year. And globally, the birth cohort is about 100 and something million, if I remember correctly. So even a childhood vaccine that was given to every child in the world twice would only be 200, 300 million doses. So flu vaccine is the most used vaccine in the world. It's surprising, because you need to have it every year. Other vaccines, you just get it once or a few times. One of the problems we have with flu vaccine is because of the way it's produced, there's a long production cycle, 6 months, 5 to 6 months at the moment. So it means for the vaccine that some of you may have got quite recently for the coming winter, the vaccine production cycle would have started probably in March, February or March. The strains would have been selected in February by the World Health Organization as a prediction of what might be circulating in the US this winter. So that's a kind of guess or a kind of prediction. And then based on that, the companies will take the viruses that are recommended for inclusion in the vaccine, they'll grow them in the eggs, and the whole process takes months and months, because they need to grow it up and then put that virus into other eggs and then grow those up and so on. And it just takes a lot of time to make a lot of doses. The World Health Organization recommends a number of groups to receive flu vaccine every year, so it's not everybody. They recommend pregnant women, young children, older adults, healthcare workers, and those with high-risk conditions. And the reason for recommending these groups is because flu vaccine has a demonstrated benefit in these groups, and there's also a definite burden of disease in these groups. So for pregnant women, it's the highest priority because there's the clearest evidence that pregnant women suffer if they get flu. Sometimes their babies, the fetus will suffer, and the vaccine is really useful both for the woman and for their infant. Even after it's born, it can still derive some benefit if the mother was vaccinated. The last category, that those with high-risk conditions, includes things like diabetes and heart disease, but also obesity. And so in the US a few years ago, they did a calculation and figured that 60 or 70% of people in the US fall into one of these groups, because there's a lot of people with high-risk conditions in the US. So they gave up with the risk group recommendations and just made a universal recommendation. It was much easier to just say everybody should get it than to figure out if people are in a risk group or not, because almost everybody's in a risk group in one of these categories. I'm particularly interested in studying influenza in older adults. In the past, I've done studies in children and younger adults, but I'm particularly interested in studying older adults because it's the group with the highest disease burden. So in the US, 60% of all influenza hospitalizations are in older adults, and 75% plus of the mortality from influenza is in older adults. And that's despite having high vaccine coverage with standard influenza vaccines that I introduced on the previous slide. So the vaccine's grown in eggs using the technology from the 1930s. So it's a question like, what can we do better to reduce disease burden in older adults? And there's a number of different ways we can think about it. We could think about using more vaccines in older adults. The coverage now is maybe 50% in the US in older adults, maybe 60 in some places. Could we get it even higher? But I don't think that's going to reduce the burden a lot because the vaccine's not working that well. So could we use better vaccines? And that's the topic of my talk now. Another separate choice is thinking about how we could reduce flu in the whole population. And an idea for that is to vaccinate children, because children are responsible for the most transmission. So, I mean, that's another possible strategy, is to get really high coverage in children, which we haven't got in the US or in Hong Kong at the moment. So one of the issues with flu vaccine is that they don't seem to work that well. Typically, effectiveness, sorry, the number's a bit small. Typical effectiveness is in the range of probably 40 or 50%. It's in the column, the second column. 50%, maybe 60% in some years. But then in the last few years, we've had a few years in the US where vaccine effectiveness is down towards 10% or even less, which is quite concerning. And I'm going to come back to this issue a bit later in my talk, this problem with vaccine effectiveness. So the vaccine particularly doesn't seem to work as well in older adults. Also, the vaccine doesn't seem to last for that long, so we need to be careful about when we give vaccine. So this is a study from Europe suggesting that the flu vaccine boost immunity for a while, maybe 1 or 2 months, you get a reasonable level of protection, but then the immunity provided by the vaccine declines after that with 2 mechanisms. One is that the immune response itself comes and then goes, and the other reason is that the flu viruses that circulate change over time. And so as time goes on, the vaccine strain becomes kind of outdated and not as, the protection against the vaccine strain is not as useful maybe now as it was before. So this is the issue about the strain changing for H1N1 and then H3 and then 2 different B strains. Each of the vertical changes in this panel is showing the strain needed to be updated by the World Health Organization. So there were 26 vaccine strain changes in 19 years, more than 1 per year. So the vaccine is having to continually change to be updated to keep up with the flu viruses circulating. And often when we look at the match between the circulating flu viruses and the vaccine flu viruses, they're not very well matched. It's kind of difficult to keep up with what's circulating. And it's difficult to predict ahead what will be circulating next year. And that's a very active topic of research in my field at the moment, is trying to have a better prediction of what's going to come next year. In terms of timing of vaccination for the US, so I've plotted a whole load of flu seasons on this figure. In the US, typically you'll expect the flu season to begin maybe November at the earliest, maybe December, and then go up to a peak, which could be in earliest peaking in December, otherwise January or February, and if the season's very late, maybe March. I showed earlier that the flu vaccine probably provides protection for maybe 5 months, and on the blue arrow is 5 months from the middle of the vaccination period. In the US, is between late September and early December. Although now there's a fight to get the vaccines out to the market earlier, and I've heard of some vaccines in the US being available even in August. So you can get vaccinated earlier, and the vaccine companies all like to have their vaccine available sooner to increase their market share. But bearing in mind the issue about the decline in protection after vaccination, it may not be ideal to get vaccinated in August. You may want to wait a little bit until maybe October to get vaccinated and have a higher level of protection during the flu season. So that's fine for the US. Protection for 5 months is good. But this is what we have in Hong Kong. We have flu most of the year. So in any given month, we can find children with flu in hospital in Hong Kong. And we usually have a winter peak around December, January, or February. And we sometimes have a spring or summer peak in May or June or July or August. I don't know why we have this kind of strange seasonality in Hong Kong. I asked one of my postdocs about that a few years ago and still haven't got an answer about why we have this strange seasonality. It doesn't seem to be clearly driven by environmental factors or behavioral factors or school patterns or whatever. It's a bit of a mystery. But it presents a problem because for our elderly in Hong Kong, we vaccinate them in probably October, November, December, but we need them to have 9 months of protection. And the vaccine may be only giving them 4, 5, 6 months of protection. So they're not covered by the later peaks. So it's an issue for Hong Kong. And not only Hong Kong, but also any subtropical or tropical location where 50% of the world's population live. How can we provide year-round protection or better protection for older adults? So I'll summarize the background so far. There's a lot of disease burden in older adults, which makes me interested to study it. The vaccine doesn't seem to work as well in older adults. The protection doesn't last for 12 months. So 2 possible solutions. 1, what about if we give the vaccine every 6 months instead of every year? And I'll show a study of that. And then secondly, what about these new enhanced influenza vaccines that I'll introduce in the second half of my talk? Would they be better options in Hong Kong or in the US? And what would be the best way to use them? And one of the issues that we're wrestling with in influenza research is the problem of repeated vaccination. And I'll show you some data to explain to you what the problem is when we get there. So 2 ideas. One is twice a year vaccination. And so I've got a study to present you, which is the light blue circle, once a year vaccination versus twice a year vaccination? And then separately, what about the post vaccine? What about the enhanced vaccines? And there are a number of choices there which I'll get to. So what would be better? So working with US CDC, I've been able to establish 2 randomized trials in Hong Kong to look at which strategies might be better for older adults. The first study is relatively smaller, just 400 older adults, randomly allocated to either once a year or twice a year vaccination, and that's been going for a few years now. And then the second trial is a bit larger, with almost 2,000 older adults, giving a number of different enhanced vaccines over a number of years. And I've got some data from both of these studies to share. In terms of twice a year vaccination, there was a precedent for doing that in Peru. 1 year, the government in Peru tried twice a year vaccination. And in Hong Kong, we tried it as well in 2015. So the headline in the newspaper said, government launches the summer flu jab. So we have a winter flu jab every year, like in the US. We launch a summer flu jab as well for Hong Kongers after the wrong vaccine circulated last winter, which is nonsense. It's like, I need to call the journalist and try and explain to them what's the difference between this vaccine and the flu circulating strain. So the vaccine doesn't circulate. There's a circulating strain, and it was mismatched with the vaccine strain. And as a consequence of that, because the vaccine strain maybe didn't provide that much protection against what's detected in the community, the government decided they'll have an update. So they'll get the new vaccine, which is the Southern Hemisphere vaccine for the Southern Hemisphere winter, which is the Northern Hemisphere summer. So we'll have the summer flu jab in Hong Kong using the Australian vaccine. So we brought it in. I won't show any data. It did seem to improve protection for older adults in the second half of the year. And that's also what we're going to look at in my study. So my trial, I need to find 400 older adults, randomly allocate them to get vaccine twice a year, or get vaccine once a year and get a placebo once a year. In order to get permission for this study, I need the IRB, I need special permission from the government, from the drug office, to use the Southern Hemisphere vaccine and to use a placebo as well for clinical trial. And then I need to find 400 older adults who are willing to join the study, which involves a lot of blood draws, a lot of text messages, a lot of phone calls, and whatever, to keep track of them over 5 years. And we're now getting towards the end. We're just doing this vaccine now, this year 4. So I've got a ton of blood in the freezer waiting to be tested to figure out what's going on for these older adults. There's no similar study like this has ever been done before. There's a recent publication from Singapore of just 2 vaccines, so like the first 2. So this one, and this one. There was a study published in Clinical Infectious Diseases. But for this, it's unprecedented. We picked older adults aged 70 to 79 because it's a small study. We don't want to have too wide an age range. And then we had a number of exclusion criteria. For the enrollment, we used a couple of outpatient clinics near my university. So in those outpatient clinics, there's a lot of older adults coming in every day for various reasons, including getting the annual flu jab. So we jumped in and then enrolled some of these older adults to join the study. We have permission to take the photos for these presentations. And so you can see we take the blood, we give them the vaccines, and then we follow them up over from year to year. If they get sick with a flu-like illness, we'll arrange to go and see them in their home to collect a swab that we can test to see if it was flu or not, or something else. And it's not easy in these kind of studies to keep the participants coming back again and again every time. It's tiring for them, and it's a lot of work for us to keep doing it. We recently switched. We used to do all the data collection on paper forms, but we recently switched to using these iPads. We use RedCat, which is an electronic data collection platform. It's more convenient in the long term, but it's tough in the beginning to get the staff to use it because it's a lot more fiddly than writing on paper forms. Because the study is a small study, only 400 older adults, we can't use clinical outcomes. I would like to use clinical outcomes, but when I was thinking about this study, I did some calculations. I figured for an older adult, the chance of them, after being vaccinated, the chance of them getting flu is about 1% per year, 1%. And I think having twice annual vaccination could reduce the risk of that a little bit. But if I want to do a randomized trial to show a difference between, say, 1% and 0.9%, 10% reduction, clinically significant, or 1% versus 0.8%, I need a massive sample size, like 10,000 elderly, which I can't find. 10,000 elderly to do this kind of study, and I don't have the money to do a study of 10,000 elderly. So instead, I can only use proxy outcomes. So this is like biomarkers, and in the context of vaccine trials, we're going to use a measure of the immune system's response to the vaccine. And for flu, the validated outcome is called a hemagglutination inhibition assay, which uses a really funny property of influenza viruses. You wouldn't think it, but influenza viruses bind to red blood cells. So what it means is, if you get your laboratory vials and you put the medium in and then you drop some red blood cells in, after an hour or so, the red blood cells sink to the bottom because they're heavier than the medium. And so in the bottom of the little vial, which is a conical shape, there's a red dot in the bottom because all the red blood cells are sunk to the bottom. But because influenza virus kind of binds to red blood cells, it attaches to them, and then it makes the red blood cells agglutinate, which means forming a kind of a lattice or something. Because of that, if there's virus in these wells with the medium, you get this red kind of mess instead of a clear red dot. Okay? So you get this hemagglutination, this agglutination of red blood cells. But then, if you add to the medium someone's serum, which is part of their blood, if you add the serum into the assay, if it's got flu antibodies in it, the antibodies bind to the virus and stop the virus from binding to the red blood cells. What a brilliant idea. So you catch the virus before it has a chance to agglutinate the red blood cells, and you can do different dilutions of the serum to see how much antibody is in there. So in this example, it's the same person's serum diluted to 10, 20, 40, 80, whatever, all the way. And the red blood cells don't agglutinate with a dilution of 40, but they do with a dilution of 80. So we say the antibody titer for that person is 40, and the higher, the better. So we can read off, we can put people's serum into this assay with different viruses to see what's their level of antibodies against that virus. And for the last case, this is someone's serum that doesn't have any antibodies, so the titer is undetectable. There's no detectable antibody titers, and it does happen for some people. So we can use this assay to get an idea of what the protection might be. So this is the data I have so far from the first 3 rounds of my twice annual vaccination study. So the first round, the red group is twice annual, the blue group is once annual. Both groups got the vaccine in the first round. It's vaccine versus vaccine. So it's the same. They both get this big boost from before to 1 month after vaccination, getting a big boost in the hemagglutination inhibition titer. The titers come down over a few months, and that's correlated with the reduction over time in protection. The red group gets a boost with the vaccination, the blue group gets a placebo, and so the blue group is basically flat. The red group gets this nice boost, comes down over time again. Blue group is relatively stable the second half of the year. And then the third round, this is the next winter, so both groups get the vaccination again. So blue is once a year vaccination every winter, vaccinate. And in the summer, we give them a placebo. The red group is get the vaccine every 6 months. And so the question for this is, for the increase in the titers here, and the difference between the red line and the blue line for the second half of the year, would that correspond with any kind of protection? So how do we interpret immunogenicity data? We need some way to link it with protection against infection. And there's a series of papers that suggest, not confirmed, but suggest that for every 2-fold increase you get in antibody titer, your protection improves by 20%. So your risk of influenza reduces by 20%. So an 8-fold rise would be a 50% reduction. So these people here in both groups, their titers are going from 40 to almost 320. It's almost an 8-fold rise. Probably they're deriving about a 50% reduction in their risk of infection. So maybe the vaccine effectiveness would be like 50% in both groups. I don't have a placebo group because elderly are recommended to be vaccinated. I can't have a placebo group in my study. But based on what their titers were like before vaccination, it looks like they're getting about 50% protection for the winter from vaccination. But then it's declining over time. But then it's kind of sad to see that when we get to the summer, the red group is only getting a twofold rise. So they're only getting 20% protection for the summer, more than the blue group. So given that flu circulates the year round, 20% for half the year is 10% for the whole year. So that means I'm vaccinating twice a year. I'm probably going to give an extra 10% protection to those twice annual vaccinees, which is coming back to my sample size calculation, which wasn't too far off the mark, maybe a difference of 1% versus 0.9%. Right? So it's not that much of a benefit. Maybe good. It depends on what's going to happen in the summer, basically. If there was going to be a really big flu season in the summer, then it might be a good idea, but it's very difficult to predict ahead of time what's going on. One of the things that jumps out to me as a flu epidemiologist in this figure is the difference between the slope here and the slope at the beginning. So the first time these elderly got the vaccine, they had a really big immune reaction to it. They had a really strong response, good level of protection. The second time, and also on the right, the third time or the second time, on the right-hand side of this figure, the response is much weaker. It's much weaker. So they're not getting as much benefit the second time as they got the first time. I looked in more detail. It's a little bit difficult to see here. I looked in more detail at the pre-vaccination titers on the x-axis of these heat plots and the post-vaccination titer on the y-axis of these heat plots to see what's going on. And so if there was no change from pre-vaccination to post-vaccination, I should see the points on the diagonal. For example, if I was giving a placebo, which doesn't have any effect on the immune system, it's just salt water you inject in the arm. And indeed, for this one, the once annual group, when they're given a placebo, there's no change in HI titers, just a little bit of noise because of the measurement error in the assay. The first round of vaccine in both groups, there's a whole load of stuff up in the top left. Up in the top left, it's difficult to see on the screen, but it is there. So that's indicating like good responses in most people. But looking to the top right side of this figure is kind of concerning. So like this lot, this group of people, the third time they get the same vaccine in the space of about 12 months, their responses are not that different to the response to placebo. So before the seminar, we were just mentioning that you get the flu vaccine and it doesn't seem to do that much good. This is a repeat vaccination problem. The first time you get the flu vaccine, it's good. You get a whole load of protection. But from this kind of data, the second or third time you get it, particularly with the same strains, this was the same vaccine strain every time, it looks like you don't get that much of a boost to it anymore. And it's kind of concerning for people like me that recommend flu vaccination. That it's fine the first time, but the second or third time, maybe not so much. There's two competing hypotheses for why the vaccine doesn't work so well when it's repeatedly used every year. I'll tell you what they are. I don't have any slides on them. And I don't have any data to distinguish those two hypotheses or even whether either of them could explain the data. There may be other hypotheses as well. So the first hypothesis is a kind of hypothesis about misdirection, which doesn't exactly match this data, but it matches other data that have been published. So misdirection means that when you get vaccinated every year, so I get the vaccine strain 2 years ago, I get it last year, I get it this year. When the strains have changed, if I get the vaccine this year, it's possible I have a misdirected immune response. I get the response to last year's strain, 2 years ago strain, in this year's strain. Because the body picks up, it's similar, good enough, don't need to make any new antibodies, just boost the old antibodies. So that's misdirection. The second hypothesis is that some people have got so much antibodies in their blood already against flu that when they get vaccinated, all those antibodies bind to the vaccine virus and stop it from stimulating a further immune response. So it's called antibody blunting. It's not clear whether that would really make sense because your antibodies don't lurk in the blood, in the muscle tissue, or whatever when you get vaccinated. So it doesn't make sense that there'd be all these antibodies ready to jump in onto the stuff that's just been injected from the vaccine and neutralize it before it's had a chance to do you some good. So we're kind of stuck at the minute trying to figure out what's going on with repeat vaccination. So I haven't shown the other vaccine strains. I just showed H3N2, but it's similar for the other strains H1N1 and B. The conclusion from this study so far is maybe a marginal benefit of twice-annual vaccination. 10% or 20% reduction in risk of infection. And of course, the cost of vaccinating twice a year is double the cost of vaccinating once a year. So if you do a cost-effectiveness analysis, you'd have to have a really cost-effective vaccine to say that you should also give it a second time a year to get an extra 10% benefit. I mean, it's possible, but to me it seems a little bit unlikely that it would be cost-effective to have twice-annual vaccination with that marginal additional benefit. And the problem at the bottom, the third point on the slide, we saw these repeat vaccination effects, which make me quite worried when I think about giving these participants vaccine every 6 months, 10 times in a row. I'm worried what I'm going to find when I get to the end about whether there's such a lot of repeat vaccination effects that it's no different to giving a placebo. And if I come back to my introduction, when I said there's a whole lot of disease burden in older adults in the US, despite high vaccination coverage, also occurs to me a plausible explanation for that observation is that the vaccine is not working very well when it's given every year. But that's our policy. So CDC policy, WHO recommendation, annual vaccination for older adults every year. And there's very, very few studies on what happens to people when they're repeatedly vaccinated. Very few studies. And mine is one of the few trials that would ever be done on repeat vaccination for more than, say, 1 or 2 years. So I proceed to the second half, talk about the second trial I'm doing. So for this trial, I'm looking at the new generation of flu vaccines that have become available in the last 10 years. So there's a number of ways that we can make the flu vaccine, the standard flu vaccine, better. The standard flu vaccine was developed in the 1930s, first used in the US military in the 1940s. It's been improved over the years, so it's purer now than it used to be. So in the old days, if you had egg allergy, you couldn't get the flu vaccine. Now all the egg protein's gone, so even with egg allergy, unless it's a really, really sensitive allergy, should be okay to get the standard flu vaccine, although there's a thing on the label about it, because it's so much purer now than it used to be. But there's a number of ways that we can improve the flu vaccine, and there's 3 different ideas from these 3 different vaccines. So the MF adjuvant vaccine has been around for more than 10 years. It's made by Novartis, and the idea for that vaccine is to add some kind of aluminium compound in the vaccine which stimulates the immune system. So you get the vaccine and you get this other stuff in it, which makes your body jump, and you get a really strong boost to the vaccine, which you wouldn't have got from just the vaccine strain alone. You have this other thing in there called an adjuvant. And there's quite a number of vaccines nowadays are adjuvanted. Another one is the HPV vaccine. So that's one strategy. Another strategy, the high-dose vaccine made by Sanofi Pasteur. Simple idea, just add loads more flu virus in the vaccine. So it's 4 times the amount of virus in a high-dose vaccine compared to a standard vaccine. So just a lot more virus, give someone a bigger dose, hopefully get a bigger response. Makes sense. And then the last one is addressing one of the other problems of the standard vaccine. Standard vaccine, and the other 2 as well, are from viruses which are grown in eggs. But there's an issue with growing flu viruses in eggs. So I guess you've all heard of avian flu. It doesn't affect humans, right? Because it's slightly different. Human flu is a little bit different to avian flu. If you grow human flu viruses in an egg, avian, you get some mutations. They don't make it into avian flu, but the virus from humans sometimes changes a little bit to grow better in eggs. An avian flu virus will grow fine in eggs, but a human flu virus doesn't always grow fine in eggs. So it changes a little bit to be able to grow in eggs, or the vaccine company will be forced to change the virus a little bit to let it mutate so that it can grow better in eggs. But what it means in practice is that the vaccine, before you've even started, the vaccine doesn't match as well with circulating strains as you want it to, even if the vaccine strain is the same in theory as what's circulating, because of the egg adaptations. So the last vaccine in my study, the green one, recombinant vaccine, is grown in insect cells in enormous vats in a production facility, I don't know where in the US. So they use this insect cell culture system to grow flu viruses with special technology, and then it's very straightforward to purify it, and you get very nice virus which matches what's circulating in humans. It doesn't have these egg adaptations. And so it's another idea for having a better vaccine. So in my study, I'm comparing these 4 vaccines head to head, again, recruiting older adults, regular blood draws, this time 0, 30, and 6 months, and then getting additional blood sample for cell-mediated immunity as well. Inclusion a little bit wider this time, 65 to 82 years, again, excluding those with dementia or cognitive impairment, because we don't want to deal with consent issues for those older adults, and then also if they're contraindicated. So this is the vaccines I mentioned, the 4 vaccine, Seqirus, it was previously Novartis, now Seqirus made the adjuvant vaccine. The others are all made by Sanofi in our study. And then just note that the flu block is grown in cells, not eggs. The high dose has 4 times the antigen content, and the adjuvant vaccine has antigen. So there's 3 different mechanisms for improvement. For this study, we didn't implement in the outpatient clinics. We went to the community. So my team did more than 100 of these kind of talks in community centers, where community dwelling elderly will go in the daytime to meet their friends, to do activities, to listen to health talks, or to play games, whatever they like to do together. So we arranged time slots for more than 100 of these community centers to go and do the advertising for our study. We gave a talk about flu, about how to be healthier, and then asked who'd be interested to help us with our trial. And eventually we got up to 1,800 participants, many of them from these health talks, and then some from some other enrollment strategies as well. And then for the vaccines, we're going out to the community as well. And we're collecting blood, sometimes in the same community centers as well, and also in some private medical centers around Hong Kong that agreed to let us use their facilities for recruitment and for follow-up. In terms of the characteristics of the 1,800 odd participants, half of them are 65 to 70, and then the others are a little bit older. We don't want to go too old because it's a 4-year trial, so we don't want to have older adults that are too old by the time we get to the end. Most of them have underlying medical conditions. It's typically hypertension would be the most common, and then some diabetes and some other stuff. And then 2/3 of them had the flu vaccine the year before they joined the study. So they're repeat vaccinees, and then 1/3 of them are not repeat vaccinees. This is the kind of data I got from the day 0 and then the day 30 for each of the vaccines. So S, A, HR are the 4 vaccines: standard dose, adjuvant, high dose, and recombinant. And the dots show the distribution of the data before vaccination and after vaccination, and then the line is showing the typical rise, the average rise. So in each of the vaccines, it's about a 4-fold rise in antibody titers from before to after vaccination. And there's not that much difference between the 4 different vaccines. And the other thing to note is there's a lot of variability. And something that surprises me a little bit is after vaccination, like this one and this one, those people are still having low antibody titers after they've been given this enhanced vaccine that's supposed to give a really good immune response. And I'm still trying to figure out why some people in our study don't seem to respond to flu vaccine. It's not clear why they don't respond. We can look at the post-vaccination titers, which gives us an indication of how effective the different vaccines might be compared to each other. I won't talk about all the numbers in great detail. It's kind of technical, but for H1N1, this is for H3N2, including the vaccine strain grown in eggs, the vaccine strain grown in cells, which is more like the circulating strain, and the next year's virus, which we're interested in because we often have this problem. We vaccinate against last year's virus, and then we get next year's virus. So there's a mismatch. But if a vaccine can protect against next year's strain is really good. And then this is the 2 influenza B strains. And we got a problem that 2 of our vaccines didn't include the second B because they were trivalent, not quadrivalent vaccines. So for H1, 2 enhanced vaccines do better. For H3, this last one, the recombinant vaccine, which is called flu block, this recombinant vaccine did better, particularly against the strains that are coming in the future as well. So we were quite impressed by that vaccine, probably providing better protection against H3N2, which is the strain we're most worried about from year to year. It does the most, causes the most hospitalizations and deaths when it circulates compared to H1 and B. Another way to look at the data is looking at the ratios of the titers compared to standard dose, and this will give us an idea of effectiveness. So I just want to orient on the graph. So I've got H1 on the left, the next 3 is H3 strains, and then I've got 2 Bs. And the dotted line is the same as standard dose. So this is for each of the enhanced vaccines, the same as standard dose. And then this one is a 2-fold rise and a 4-fold rise. And remember what I said about the link between the titers and protection. So a 2-fold increase would be probably a 20% reduction in risk of infection. It would mean if there was an enhanced vaccine that gave a 2-fold higher post-vaccination titer compared to a standard vaccine, then I'd expect the relative effectiveness of that enhanced vaccine to be about 20% better. And so I can see from this that in general, we're not getting above a 2-fold difference. So the enhanced vaccines are probably not going to be 20% better than the standard dose vaccine in general. For this study and for the other study, I also went to follow up the old people in the community when they got sick. If they had flu-like symptoms, even without fever, we took swabs and then we tested for flu because we want to see if there's any evidence of protection against clinical influenza from the different vaccines. Unfortunately, we had the flu strain, this B. Phuket, which wasn't included in 2 of the study vaccines. So it's kind of annoying that 1 year we do the study, we have the strain that was the worst one to compare because 2 of the vaccines didn't have it in. They were just trivalent vaccines with 3 strains, not quadrivalent vaccines with 4 strains. So take-home message from these results, the enhanced vaccines probably give better protection against influenza than the standard vaccine, but maybe not 20% extra protection, maybe only 10% extra protection. So it comes back to the same story as with the other study and with my comment on sample size at the beginning. If I wanted to do a clinical trial to compare these vaccines against laboratory-confirmed influenza, clinical outcome of patient significance, if I wanted to do that, I'd need probably 10,000 over dose plus, which is not easy for me to do by myself with my team in Hong Kong. Maybe it could be a multi-center study around the world. Oops. I want to show again the issue with repeat vaccination. So now I stratified the participants into 2 groups. 2/3 of the participants were repeat vaccinees, and those are shown by the solid lines. And 1/3 of them were not repeat vaccinees, and they're shown by the open symbols and the dotted lines. And for those who were not repeat vaccinees, like these, for standard dose here, the ones who didn't get vaccinated the previous year, they started off with less protection because they didn't have a vaccine the last year. So they start off from a lower point, but they get a much better boost. So that's going 2, 4, 8-fold, 50% vaccine effectiveness for those people. But these ones who were vaccinated the previous year, they're just getting a 2-fold rise. So they're probably only getting 20% benefit from being vaccinated. If we were going to judge how effective or cost effective is a vaccination strategy in the community, what I've seen in the literature is people using something like 50% protection from randomized trials, which typically use people who are not repeat vaccinees, having this kind of data. So it looks really good. It looks like you get 50% reduction in disease burden by vaccinating people every year against flu. What those studies have failed to recognize is that when you have vaccination every year, you have this repeat vaccination effect. And so you don't get a 50% reduction in disease burden every year. You are starting at a higher baseline. So it's not the protection is not going to be just that 20% from that change, but it's not going to be as high as 50% because these repeat vaccinees are not getting as much antibody and therefore as much protection as the first-time vaccinees. So it's kind of troublesome. One of the questions we had, the scientific questions when we formulate this study, is whether the enhanced vaccines can overcome repeat vaccine effects. So we knew about repeat vaccine effects for standard vaccines, but they've hardly been reported for enhanced vaccines. Hardly anybody's looked at them because the enhanced vaccines are quite new. But in the right-hand side of this figure, we see repeat vaccine effects for the enhanced vaccines as well. So it means if you were vaccinated the last year, the enhanced vaccine still can't give you as much of a boost as compared to someone who didn't get vaccinated last year. But if we compare the slopes, and I have other results which I won't show today comparing the slopes, if we compare the slopes of green, orange, and purple with the slope of the grey line, then the slope is still better. So the enhanced vaccine is doing better for the repeat vaccinees, but it's not completely overcome repeat vaccination effects, which is a bit of a shame. It would be nice if it could. So the first year of the study is the results I've shown so far. And then for the next few years of the study, we're going to go further. And we've re-randomized the participants to receive either the same vaccine again and again. So the first arm is getting standard dose every year. But then the second arm is getting standard adjuvant. Down here, we've got adjuvant, high dose, and all kinds of other combinations as well. So I want to look at how the immune responses vary and whether combination strategies, for example, getting high dose and then adjuvant or whatever, would be even better than getting the same enhanced vaccine every year. So by point of context, in the US, the high dose vaccine, that's the orange one, has 40% market share in elderly, 40% market share. It's used a lot now. The green one has come into the market a few years ago. It's growing its share, not used that much, probably less than 10% market share for elderly flu one. And the purple one is not used in the US. In the UK and in Australia, they've switched entirely. So all older adults who get flu vaccine in the UK and in Australia will get the purple vaccine, the adjuvant vaccine. They don't get standard anymore. They don't use it for elderly. But I have a feeling that the optimal strategy may not be to choose one as the vaccine to use every year. For example, like the UK using the adjuvant vaccine every year. The optimal strategy for older adults might be to do these combinations. So have adjuvant for everybody 1 year, high dose for everybody in the next year. Or if you've got good medical records, you can have 50% having one, 50% having the other, and then you just switch it over the next year because you know what people got based on their medical records. So that's the plan. And I'm now in the middle of year 3 vaccinations. So I haven't got any data for year 2 yet. I'm now in this one, and we've got 1 more year to go. And then we'll finish the study. So to summarize from the pivot study, there's a marginal improvement in protection conferred by the enhanced vaccines, and the flu lot did particularly well for H3N2, but there were also clear repeat vaccination effects. Again, same as with the other study, the vaccine strains were not changed in these analyses, but then in other years, the vaccine strains have been updated. So maybe there'll be a less of a repeat vaccine effect when the strains change, maybe. So I just have a few slides to wrap up. So for retain marginal benefit, maybe 10 or 20% extra protection. For pivot as well, some improvements. I didn't show the cell-mediated immune responses, but those are also boosted by the enhanced vaccines. And there's repeat vaccination effects that were overcome to some extent. I'm still thinking about a lot of questions. So I found in the last 15 years I've been studying influenza, I have a lot of questions. I do some studies to answer those questions, but then I end up with more questions than I started with. So it's like never ending. I thought these studies would be able to answer some of my questions, but I've discovered from the findings so far that I have even more questions. Repeat vaccination is fascinating. I'm worried about whether there's any long-term advantage or disadvantage of twice-annual vaccination. For cost effectiveness of twice-annual vaccination, I mentioned that it's about double the cost. So for once-annual vaccination, you need to pay for the vaccine and you need to pay the person to give it. In the US, vaccine costs about $8 to $10, and paying the person to give it is another 10 maybe. So 20, I guess, in the US for annual vaccination. For twice annual vaccination, it's another 20. So it's 40 total for the year. So you could judge whether the benefits you'd accrue from having twice annual vaccination would be worth paying $40 for. For the enhanced vaccines, all three of the enhanced vaccines that I mentioned cost $30, not 10, 30. So the cost of administering is 30 for the vaccine plus 10 for the doctor to give it to you or the pharmacist to give it to you. So it's 40 as well. It's the same as twice annual vaccination, the same cost. And the benefit of the enhanced vaccine is probably 10 to 20% additional benefit. So the question about cost effectiveness is the same question. Is it justified if you pay 10%, let's say if you pay $20 for standard vaccine for a certain amount of protection, is it worth upping it to $40 to have a little bit more protection? Need to do the calculations at some point to figure out whether it's cost effective or not. And in the future, I'd like to do RCT with clinical outcomes, but I think my team won't have the capacity to do it in-house. Maybe a multi-center study would be the solution. So I'll just finish. It's my last slide of wrap up. The enhanced vaccines definitely did better, but the cost was more. Twice annual vaccination might be an option for Hong Kong, other tropical, subtropical locations, but I'm really worried about repeat vaccination effects, and that's something that the influenza research community is dealing with at the moment. Why do we get repeat vaccination effects, and how can we deal with them? How can we avoid them or mitigate them? Because otherwise, I think annual vaccination is not giving the benefits that we think it should be giving. And I'll finish, just acknowledged a lot of people involved in this study is funded by the US CDC Influenza Division. So I come to Atlanta quite often to meet with the collaborators there. And then a number of other people in Hong Kong are also involved. Thank you.
So before I open the floor for questions, can I ask Mr. Cowling just to say a few words about the WHO Collaborating Center for Infectious Disease and Division and Control? Because we don't have something similar.
Okay.
Not really similar here, so we want to learn more about what the centers do.
So my team, my research group, has about 50 people. So we have people working in all different areas. It was almost all influenza, and now a little bit of antimicrobial resistance. But some years ago, the WHO approached us and asked us if we'd be willing to help them. They're not interested in the research so much. They're interested in capacity building in the world and for us in Asia. And they're interested in emergency response. So if there's Ebola, something like that, in China, can we help? So they asked us if we'd be willing to become a collaborating center. We get no money from that. We just get the nameplate, the title that we can use. And as a consequence, we need to keep in connection with WHO in 3 areas. So one is infection control. My colleague does a lot of infection control work, hand hygiene and infection control and prevention, education and evaluation. The second one is antimicrobial resistance, building capacity in Asia, particularly with training courses. We're hoping to do some training for laboratory and also for surveillance fellows. And then the third one is for emerging infections. So we are ready to help, and we promise the WHO we'll be ready to help. We'll drop what we're doing if there's an emerging infection like Ebola in Asia. And in the past, when there was an outbreak of MERS in South Korea, in 2015 we helped WHO. And in 2013 we contributed to H7N9, so this kind of thing. So the Collaborating Center is a title that we got from WHO. It's a unique thing for us. There's not a network of these centers in this area. It's a unique one for us, and it's just because we have a good relationship with people in WHO that think me and my team can help with certain tasks, and they know that they can rely on us to help. So the way to get a WHO collaborator is to be really good friends with WHO and help them out. And it's not the research that they're worried about, it's the training, the capacity building, the education, and then for us, the emergency response. But for other CCs, it's the training and that kind of stuff. Yeah. So there's a lot of WHO CCs. In Asia, there's 200 or something for all different areas in Asia. Because I've been to the meeting where they all go. Yeah. And in the US, there'll be a lot as well.
Questions?
Yes, Dr. Cowling.
Thank you for being here, really interesting presentation. I was wondering, when you did the re-randomization of the pivot trial, if you thought about having groups only vaccinated every other year.
Yeah. I know, I would like to. We have a problem that because the World Health Organization recommends everybody gets flu vaccine every year, we can't do that. I would like to do that. And I've thought about doing it in Hong Kong for a study in children, because in school-aged children in the past, we don't need to vaccinate them every year. They're not recommended group. So we could do that. And I think that there's a nasal spray vaccine called Flu Mist. It's quite widely used in the US, although it was off the market for a few years. I have a feeling that for that vaccine, getting it every other year could be optimal, right? Getting it every year might be a little bit better, but there's the repeat vaccination problem. Getting it every other year might be a sweet spot. But for elderly, there's nothing I can do because they're recommended to get a flu vaccine every year. So the only thing we can do in that study is have the standard dose and see whether, the people that get the standard enhanced, what happens to them when they get the standard dose. So the standard dose gives them a boost. The enhanced vaccine is going to give them a big boost. I'm kind of worried that when they go back to standard, their body just won't respond to it at all. It'll be like, they've gone way past that. They want the enhanced one to get a response. But that would be worrying in some sense, because it's not always possible for people to get enhanced vaccines every year. They're more expensive for sure, and they may not always be available. Yeah, no, sorry. To answer your question, I would like to buy one.
Yeah.
Dr. Samami.
Yes, some question about, because you're doing clinical trials.
Yep.
Mostly. And I think the difference you saw, like statistical difference, maybe like attribute to other factors, like what kind of disease they have already, some of them because they are aging, and maybe gender difference between them.
Yeah.
Could be, and maybe how many times been getting flu before, so their immune system already has some antibodies.
Totally.
Yeah.
So
how you control for this to see difference in these slopes?
I don't know how So there is a lot of variability, and so we randomly allocated the participants to the 4 different groups. So on average, those things should balance on average.
Right.
But I totally agree. And one of my next steps is to look at why there's all this variability. So like you said, these are the people who had a recent infection. These are the people who didn't. Maybe the younger people are higher, maybe not. Maybe the response. So this is the average boost, but there's some people getting stronger boost. There's some people getting a weaker boost. And probably, I would say, is the younger people get a better boost. Older people do not. And for male and female, we don't see many differences. In theory, there might be stronger responses in females, in theory. But it's not many people have shown that. So one of my next steps is to explain the variability in these groups. Yeah, totally. With also the medication. So statins can interfere with the response to vaccine.
Or you can control it, control the barrier using like Bayesian approaches.
Yeah, sure. Yeah, that's the next step.
Prior information about its variability, maybe you can control it.
And if you control it, you have a better explanation for everything. Yeah, and a more powerful analysis for the primary outcomes. Sure. Yeah.
Final question?
This is more on the production side. What has been done research-wise to develop a new method of creating the vaccine that doesn't take as long?
Yeah, so there's a ton of money being invested in the last few years and going forward by the NIH for this kind of question. It's really difficult. So the process in eggs basically can't be sped up. Some companies will take a gamble. So I mentioned that the production process takes 6, what is it?
Yeah, you said 5 to 6.
5 to 6 months. So some companies, Sanofi, for example, will take a gamble. So they'll look at the strains that were recommended last year. They'll gamble that it's going to be the same strains again, and they'll just start making it in February or even January before the announcement comes out. and they may gamble that there may be 1 out of the 4 strains changes, the other 3 is the same. So they lose that 1 that they've wasted the effort on, but the other 3, they're ahead of the competition. So that happens. But in terms of speeding up the production in eggs themselves, they tried so many different ways and can't figure out. For the growing in cells, it can be quicker, but then you need enormous facilities. And one of the other issues for the vaccine companies, the reason they don't particularly want to speed up the process is, imagine they've got this big facility with a bioreactor vats. Imagine they could produce the vaccine in 1 month. That means their facility is only used for 1 month a year to make the vaccine, and the other months is out. There's nothing to do. So they've got all these staff with nothing to do. So it's kind of, they've got to figure out how, the company's got to figure out how they can make the best use of the facility, maybe make other vaccine or whatever in the other months. And then it could work, because I think for those cell vaccine, it's just a matter of scale, right? So the problem is they can only make so much virus in a given vat. So if they want to make more, for more dose of vaccine, they need more vats, or they need a longer time. So they do it round 1, round 2, round 3 in the same vat. Now people are talking about other ways to make flu vaccines, which is completely different, like some kind of reverse genetics or whatever, but that's early stage. And one of the nasty things that happens, I'll tell you, with flu vaccine companies, they look at this kind of startup company making vaccine in a clever way and buy them up quickly, and then don't necessarily pursue heavily the development process, because flu vaccines are the most widely used vaccine in the world. That's 500 million doses a year, and having a new technology, right, which is different and whatever, is a bit of a threat. Unfortunately, it's kind of nasty for the flu vaccine manufacturers to do that. But there's a lot of concern about this delay of 6 months, which means that many years the vaccine strain mismatches the circulating strain, and then you get this poor effectiveness, probably exacerbates the revaccination effects as well. So it's kind of, yeah, I don't know, needs to be sorted out, I would say. Needs to be sorted out. So NIH is investing heavily for this.
So on behalf of our college, please organize for you.
Thank you. Thank you very much.
So on behalf of
Thank
our
you.
college, thank you so much for flying over from Hong Kong to Spain.
So for my MPH students, please remember that your class Wednesday, 4 p.m. Okay, everyone else, please sign in, especially the MPH students, please do. Thank you so much.